I'd like to thank you for coming this morning, and I'd like to thank Jean-Pierre for inviting me here to give this presentation. I'll be showing you some data for the first time from a study we're just now finishing up, so we're very excited about the results. As you've probably seen from several presentations here at the conference, illicit opioid use is a public health crisis in the US. There have been a variety of measures that have been taken to address this problem. The National Institutes of Health launched a very large initiative last year to increase funding for research in this area to help stem the opioid epidemic. A variety of approaches, including the consideration of safe injecting facilities in various cities throughout the US, including Philadelphia and New York, are under consideration. And the former chief of the Food and Drug Administration in the US stated that opioids are the biggest crisis facing the FDA right now. Part of the reason that he made such a statement is because, you know, the epidemic started with the prescription opioids and overprescribing, and which led to misuse, which led to the use of heroin, and then most recently fentanyl. Last year as well, the Surgeon General urged all Americans to carry naloxone as a means to address this crisis of opioid overdoses. So naloxone is a competitive antagonist of heroin and fentanyl. And we know from various studies that have been conducted in the US and in Canada that naloxone works. So in the communities that provide naloxone widely, the overdose death rates have decreased relative to communities that did not. Canada showed very similar findings with naloxone. The problem is that, you know, you've probably seen this slide several times during this conference. The problem is that the overdose death rates continue to increase. And this is the most concerning. And the most recent rises have been due to the synthetic opioids, including fentanyl and carfentanil. So while these programs are effective in various areas, there's a lot of room for improvement. And so this is a paper that I came across very recently that I thought was really interesting. They were discussing the use of naloxone for treating opioid overdose as an intervention. And this is a sentence that was in the abstract, which I thought was extremely timely for the presentation that I will be giving. So they say that effective use of naloxone in community settings requires screening to identify patients who are at risk of opioid overdose. They also talked about discussing naloxone use with patients and their relatives, and the importance of providing appropriate training. So these are all topics that I'll be discussing today in the lecture. So 5 years ago, when this epidemic just started to take off, we wrote a grant to study this type of approach. It was very novel at the time, and only a few cities in the US were implementing it. And the question that I had was, how can we maximize the effectiveness of naloxone? So we concentrated on the training, because at the time, and even today, the standard naloxone training is very brief. It's maybe 10 or 15 minutes where the people who are provided with the naloxone kits are just, we explain to them what an overdose looks like when somebody has used too much heroin, and then, here's the kit, kind of thing. So we thought that was insufficient. So we have two types of training in our study. One was, we call it extensive training, and the other is training as usual. So all of the participants in the study we have subjects, and then we had significant others. So every person who enrolled in our trial had to bring somebody in who was close to them, either a family member or close friend who kind of, you know, were in close contact with the research subject. So all of them received the standard training. And then we randomized people into the extensive training group or to the training as usual. And we stratified people based on sex, so we weren't sure if there would be differences in, you know, the propensity to use naloxone among men versus women. We thought maybe that severity of drug use would have an impact. So we used the Addiction Severity Index and had a cutoff score of severe versus non-severe. We also tried to enroll people from a broad, you know, range of types of situations. So some people were recruited straight from an opioid detox center. So these people were heroin users who had been detoxed and they're at high risk of overdosing. We included people who were in treatment, so they were maintained on buprenorphine or methadone. And we included people who were not in treatment and not interested in it. So they were, you know, ongoing heroin users. The extensive training took about 2 hours, an hour and 45 minutes or so, and we included lots of different components. So we taught people, you know, how to prevent an overdose. So we concentrated on teaching them not to inject by themselves, not to mix drugs. So, you know, if you use heroin in combination with alcohol or with benzodiazepines, it increases the risk. We taught them that if they were not able to obtain their opioids for some reason and wanted to start using again, that they really should start with low doses rather than go back to the dose that they had been using. We taught them rescue breathing and CPR, cardiopulmonary resuscitation. We also simulated an overdose situation and we had one of those dummies, and we had them actually practice on the dummy how to do the rescue breathing and how to administer the naloxone. The training as usual group just watched educational videos about hepatitis and HIV for about 2 hours. And again, just to remind you, everybody received the standard 10-minute training. So we divided people into 3 groups. One was where the subject and the significant other both received the extensive training. Another group was where the subject received the extensive training and the significant other, we just received the training as usual and watched the videos. And then the third group was where both the subject and the significant other received the training as usual. So these were the 3 comparison groups. You know, we considered using a fully balanced design, but the power to do that study would have been required too many research subjects. So we restricted it to the groups that we thought were the most relevant to answer our question. So after they received the training, we followed everybody for a year, and we measured all kinds of different things. So we looked at, we had them complete questionnaires about opioid overdose knowledge, so you know how they could recognize an opioid overdose. We asked them about their attitudes about using the naloxone, so you know their feelings of competency. We measured the naloxone kit use, we measured their interest in treatment, we measured heroin use as well, both self-report and based on urine drug screens. So one of the criticisms of this approach early on is it's a similar criticism as, you know, providing clean needles. You know, if you give a drug user clean needles, then that's going to perpetuate the drug use, and so, you know, that's a bad thing. With the naloxone kit, people were saying, you know, oh, you're just giving them a safety net, they're going to increase their drug use. So we monitored this very carefully in our study. We also asked them questions about how they use the heroin, you know, detailed questions about the behaviors around their use. So these are the demographic data from the 3 groups. I know you can't see it very well, so I just summarize it for you. So these were mostly men. About 3/4 of the participants were men, and as I said, we stratified, this variable across the 3 groups so they were evenly distributed. About 75% of the participants were over 40 years of age. They were mostly Black and Hispanic, so New York City has a very diverse ethnic population, so it's reflected in our ethnic stratification. And we also stratified subjects on the type of user and the severity of use. So about the same proportion of people were in treatment versus out of treatment, so about 45% in each group, and about 10% had been recently released from a detox center. Most people had insurance, but very few had jobs, so they were unemployed. And the study completion was similar across the 3 groups. So we powered the study based on a particular overdose rate. And the rate that we ended up observing in the study was about 2 to 3 times higher than what we had initially estimated. And again, this was partly due to the introduction of fentanyl during the course of the study. So we've received reports of 95 subjects who used the naloxone kit during the course of the year-long study. So they used it to rescue somebody else. So several of the subjects actually ended up using the naloxone more than once. So for each individual overdose reversal, we had 170 reports. So this was kind of an interesting finding for us because some of the subjects became kind of like the go-to person in their neighborhood. So they, they used the kit on a person, told people in their environment that they had been trained on how to do this. So one guy actually used the kit. The second time he used it, someone came, they ran and asked him, to come, and so he came with them and then rescued somebody. The third time, somebody came to get him, but he wasn't there, and so they knew where he kept his naloxone kit, and so they grabbed it and used it on someone else. So it was kind of this very organic kind of process that was happening for some people. 164 of the 170 reversals were successful, and 6 were unsuccessful. So these were fatal overdoses. So that was very nice to see. Of the research subjects themselves, 18 reported experiencing an overdose during the 12-month study. And of those 18, several had multiple overdoses. So most had only 1 overdose during the course of the study, but we actually had one person who reported having 10 overdoses. So this is, something obviously that's very distressing. So there were a total of 28 individual overdose events. 8 of the subjects died during the study. 2 experienced a fatal opioid overdose. 1 died of what was characterized as a lung problem. 1 died in his sleep. So we're suspecting that those were related to an opioid overdose. 1 died from surgical complications, so we know that that was not opioid related, and 3 died from unknown causes, so we were not able to track down exactly why they died. But this death rate was much, much higher than we were expecting to see maybe 1 based on the data that we were evaluating at the time that the grant was written. So what I'm showing you here are results of the questionnaire about knowledge of opioid overdose on the top, and also the competency scale, attitudes about using naloxone. So all 3 groups, from the pre-training period to the right after training, reported an increase in overdose knowledge and in their willingness to use the naloxone kit. So that was encouraging. There was no difference across the groups in terms of the knowledge over the year-long study. So there was one study that was conducted, that I reviewed when I was writing the grant, that showed that it seemed like the knowledge decayed over time. So they only went out to 6 months, but they were starting to see a decrease in the knowledge retention. But we didn't see that, which was nice. So everybody kind of retained their baseline level of knowledge, and they reported that they would be, equally willing to use the kit, regardless of the training condition. We also looked at the data as a function of the probability of kit use as a function of the type of user. So this is across the year-long study. Each tick mark here is use of the kit. And you can see that whether somebody was an illicit opioid user who was just continuing to use the heroin, or if they were just recently detoxed, or they were maintained on methadone or buprenorphine, they were all equally likely to use the kit. Where we did see a difference in terms of kit use was as a function of training. So both extensive training groups, this is the two extensive training groups that are right on top of each other, were using the kit much more early on compared to the training as usual. And the extensive training with the significant other. So when we both trained both of the people together, the kit use increased in probability over time. So that group was the one that continued to be more likely to use the kit compared to the other two groups. So we think that this was, a very important finding. It's one thing to give out a kit and tell somebody how to use it. In just a brief training, but it's another to have them actually use the kit. So we also monitored their interest in treatment. So these are the participants who were ongoing opioid users who were not in treatment, and we looked at their interest in treatment both before and after an overdose event. This is a small but statistically significant increase here. But we think this is important because, these people are very difficult to engage in treatment. If they're not interested in it, they're just not, going to make an effort. But observing an overdose event is it's very intense, as you can imagine. And, we think that maybe this is an opportunity to engage people in treatment. With regard to the question about whether or not heroin use would increase, in the people that we gave the kit to, the answer is no. So we found that, if anything, heroin use decreased over the course of the trial. We have no evidence that it increased. My close colleague on this study, Jermaine Jones, wrote a paper, an interim analysis paper, describing these findings. There was no increase in the severity of addiction as a function of the availability of the kit. So we had several conclusions from this study. One is that drug users can learn how to recognize symptoms of opioid overdose, and the knowledge is sustained. So this was one question that was raised early on in the availability of this program, is whether or not you can actually teach a drug user how to use the kit. A drug user or somebody else who's not medically trained. And the answer is yes, you can, and they can keep that knowledge for a long period of time. So we collaborated with Dr. John Strang and Joe Neal at King's College London, and did a sub-analysis of our data. So we conducted 40 interviews and did a qualitative data analysis. And we found that people who use opioids are very competent at responding to an overdose. I think the biggest point that we're making from our study is that the type of training really does matter. The presence of a significant other is obviously very important. And, the 10-minute training, while it's, sufficient, it's not really adequate. And for sustained use of the naloxone. We found that heroin use did not increase after naloxone is provided. The period immediately after an overdose might be an opportunity to engage people in treatment. But we also still need to counsel users about the risks of using alone. So these were data that we collected from both intravenous and intranasal users. And you can see that 77% of the IV users and 60% of the intranasal users report using by themselves. So that's obviously a risk factor for overdose-related death, or opioid overdose-related death. If they're using by themselves, then there's no one around who can rescue them. I saw a lecture not too long ago by Alex Wally saying that even when people are in the same apartment or house, they'll oftentimes go to the bathroom and inject by themselves, and they still die there. So we have to get the message out to the users that, you know, it's very risky to do this. And only a small fraction ended up using with someone else. So I would like to thank NIDA for funding this project, and my lab for helping collect the data, and my colleagues, who I've been working with for a very long time. Dr. Levin gave a lecture here earlier this week. Dr. Haney also did, so I think our group is fairly well represented at this conference. I would also like to acknowledge in particular Dr. Herb Kleber. He was the head of our division for a very long time, and we all worked very well together, and he died earlier this year. So we're all still very sad about that. And just a few days ago, Google Doodle honored him because he was really a game changer in terms of how to view drug addiction, and he touched very many lives. So I would like to acknowledge his mentorship and collegiality. And I would like to thank you for your attention.
Thank you very much, Dr. Comer, for this very interesting speech. Je vais continuer en français finalement parce que comme on est en France.
I'll continue in French because in France we speak French, so forgive me for this detached introduction, but Madame Comer has to take her flight very soon, so this is a subject that concerns us all, and that is reducing risk. We all have been thinking in that mindset for 30 years now, or more or less, and we've benefited a lot from the experience of risk reduction among our colleagues from abroad, and it's that kind of network that has allowed us in France to save us from a catastrophic situation 30 years ago to sometimes even become an example for this subject of risk reduction. What is astonishing, and with the opioid epidemic, there are 70,000 deaths in the United States per year, but in France, 500 deaths per year, whilst we should proportionally have 14,000 deaths per year. So I was wondering, and I was asking myself whether this situation is due to our policy of risk reduction. Probably it is one of the reasons. It is probably one of the reasons. If we look at this, first of all, pharmaceutical labs do no publicity about their dangerous medicines, and that has always been the case in France. The second is the prescription of opioids as to resolve pain, as anti-pain, and Mr. Kushner said this yesterday. For years, morphine was very difficult to prescribe in France. We were very underrepresented. I'm a cardiologist. I went to the United States. I had some morphine and it was very difficult in France. You had to go to the pharmacy. It was much harder than in the United States. The third port was, of course, the syringe exchange programs, where we have been, or at least the non-governmental organization, we have been precursors, but that was a big problem in the United States. They didn't like it, and unlike that, we didn't have the right to substitution treatment, but they had developed, for example, in New York, they had huge methadone programs. So you see, I think it is not the only reason, but you see that there is one reason at least, and all of these elements have to be at the forefront of our thoughts. And the access of all the use of drugs, as long as they're catalogued as a drug, they're taken on by the Social Security. And I realized that in your presentation that many have insurance. So to work with self-support associations, that is also fundamental. We have to manage to get all the messages, and the marvelous messages on naloxone that you've given us is all obviously done with the users. And you can see how it is very interesting to imagine how those users will have an effect on other users, because they will be giving them advice. So in the end, the consumption rooms are a very important element in France. In France, we're backward this. We have 2 for France, and so what is risk reduction? It's to have a policy based on evidence and proof and human rights. And if we don't use that, we will be taking risks. And that is broadly, that is a mini presentation that I've given you, but I know that our friend Joan COLOM, who in Catalogne has developed the principle of risk reduction in an exceptional way, will be showing us now how they do it.
Merci beaucoup.
Well, thank you very much indeed. Once more, thank you for inviting me, for giving me this opportunity. My friend Jean-Pierre and ATHS, I don't know if they are in the room right now, but thank you in any case for granting me this opportunity to present something that is extremely fascinating. And that is risk reduction. And with this, I will try to explain today the preventing overdose. Thank you very much, Mr. Chairman, for this introduction. He was saying before, what is risk prevention? It is the key element. I would say it's a change of paradigm of the last 20 and 30 years in drug dependency. The goals are quite clear. In other words, when the AIDS epidemic came several years ago, and many countries managed to reduce the risk in many countries, and there was a report in the United Nations that said, as it should, that what is most important is to conserve life even before trying to change or modify drug consumption. The most important value was life without any doubt. And so reducing mortality, reducing morbidity, and the infections because of the use of drugs, the consequences to prevent these infectious diseases and increase contact and to retain that contact with care services. That's also important to reduce risk, reduce social deterioration, promote and improve the quality of treatment, and promote referral to treatment. Here in this room, there are many psychologists, but I don't know if you remember the phases of change of PLÉNIÈRE. We in the 80s, if somebody was not aware enough to start us treatment, that person was not accepted. And what were the consequences? The consequences that they would be out on the street without any care or support, zero treatment. And why did we do this? Because without motivation, it was thought, there couldn't be treatment. And I think that we turned that paradigm around, and we said, first of all, we will go to them, then we will motivate them, and finally, if necessary, we will treat. And this, Prochaska refers to this as contemplative. It was not being considered in addiction. Only the action phase was being borne in mind, the intervention phase or treatment. But in fact, it is fundamental to promote referral in that way. And in the end, what that involves, as the chairman said very clearly, is a vision of human rights and public health and improvement of quality of life and fairness with regards to that. So it's not just us, but the European Drugs Observatory says that there are 7 key actions to reduce risks: access to syringes and injection material, treatment with opiate substitutes. And they put it in this order of priority because, look, when it says access to syringes and treatment with substitutes with the maximum coverage, they say, and we'll talk about that more later. Obviously, vaccinations, A+B, and screening of infections, treatment of the infections, education for health, safer injection, sexual health, combined interventions, and adapted to the local situation and to the consumers of the outskirts of Barcelona. It's not the same as the center of Barcelona, but certain neighborhoods in Paris or Marseille are different to the city center. So you have to adapt to the location and to the place. Working on the street and centers for consumption. And these are the 11 programs that we are developing right now, which are catalogued as risk reduction. The first one will be a program with opiate agonists. And here you can see that we have a very, very high coverage. It is a high coverage when more than 40% of the number of drugs users of the countries are covered. And we are very much above that figure. And so therefore, we are covering the WHO goal. What has this involved? A reduction of mortality because of overdose, a reduction of consumption, illegal consumption of opioids, an increase of continuing treatment, and a reduction of criminality, and an increase in quality of life. Now, look at the number of people that we have with a substitute treatment with methadone. We have this number on the screen, and we use 7,557. And not only in the centers for treatment, it's also done in primary centers, in special risk reduction centers, in hospitals, in therapeutic communities, in community pharmacies, and in prisons. So we were the first prison in Spain which involved the methadone maintenance programs several years ago, and we have almost 544 people in treatment programs in prisons. And later also we had a high methadone coverage. We had buprenorphine and methadone, also situated in all areas. Now, the program of syringe exchange. This is another fundamental pillar for reducing risk. This average is not right because last year we extraordinarily increased the number of syringes that we handed out, more than 1 million. Free of charge. This is the exchange kit. It's got the syringe, the colisopropylic. It's got a little cup because that's important because with the prevention of hepatitis C, the paraphernalia, it's got information. And it's a kit with various different items and information also, and also a diagram. And this is going to be linked to an app And by geolocation, wherever you are, it's going to tell you where you have an exchange program and with what timetable and when you can go and pick up your syringes. We don't call it exchange program. Now we call it a distribution program, because although at the beginning, when we started this program, we tried to achieve the maximum return of used syringes. But the main objective, however, is that each user has those 300 syringes per year. That is the main objective. If on top of that they give the used ones back, then we can give them a hug. But what is most important is for them to have the clean ones. Reducing the infection and reinfection with HIV, hepatitis C, better practices of consumption without risk, increase of contact, because having so many exchanging points, we have more than 600 points, and that means that there's a human contact, there's a personal contact, there's less cost of treatments, less infections, of course, and also we've managed to reduce the amount of items that have been thrown away in the street. And so, can we go back one slide? Is it possible? Well, I can. You can with your remote. Okay, I'll do that. Now, yesterday we were talking about the average syringes. Right now, this situation is not right. We're above 200 users per year, which according to the World Health Organization, it's a high coverage, 200 syringes per user per year. And that, let's continue now. This is the number of syringes handed out in 2018, 1,045,225. And before, we have all the distribution points, 622 exchange locations. And here, another program which is important is outreach. These are out on the street. These are very highly specialized. They go through different environments and neighborhoods. They work on site with the users, and they work with people who do not actually go themselves to the treatment centers. They don't go to the vein injection centers or the other centers. We have mobile unitors. If you don't go, we will go and see you. And these mobile units, we have 6, and 3 have a supervised consumption room. So these mobile units have the space for supervised consumption. And we have 16 centers for harm reduction centers. And what is important here is the welcome and active listening. Not to have any moral criterion in the relationship, to deal with the request, and not to judge the consumption at any moment in time, but to try to get the motivation and that confidence and trust that will provoke among the users an improvement in their behavior and of change. The classical drugs users, if you could say it in that way, is a person whose main objective one day after the other is to get the drug, and within 10 minutes they inject themselves, and they do it 1, 2, 3, 4, 5, 6 times, or times a day, or they inhale it. Do you know how important it is for these people to go through that change, to stop, to change direction, cleanliness, dental hygiene, change clothes, a hot coffee, a meal, a shower, active listening, to be listened to. That is the change, and that is why we so passionately believe in all of these possibilities, all this potential. So we have to listen to that story, and from that point, changes can occur. These are the 16 centers that we have. In all of them, obviously, there are syringe programs, exchange programs. In 13, there are consumption rooms. There are programs of substitute programs. There's health, education, and social care, and obviously there's overdose prevention, which we will look at more specifically. These are the supervised consumption rooms, 13 rooms in Catalonia. So there's 7.5 million inhabitants, 10 fixed, 2 with smoking rooms, plus 3 mobile units. It's the goals or the objectives of these consumption rooms are not we didn't explain, but there are a whole load of also of secondary objectives which have to do with contact, proximity, and possible change and referral. When we closed the most important of use of drugs in a neighborhood in Barcelona, it's a neighborhood that was close to the port area, more than 800 people began a treatment with substitute use. So people who would never have begun treatment, but with this supervised injection room, after having contact with a professional, after the supervision of their own injection, that person began a more ambitious treatment goal. We also prevent overdose there. Now, look, for example, at the number of uses of the rooms in Catalonia in 2018. 146,916. One use is one entrance into the room. The same person come in several times, but there are 3,675 users that have been identified. Obviously, these rooms are intravenous because we have fewer inhaling or smoking rooms. We have 21,843 rooms for inhaling. So how do we treat the infections for these people? And for that, we have a particular special hepatitis C program for drug users, and I explained that yesterday, so I won't repeat it. And here we have peer-to-peer education or snowball, and we try to train all the users in healthcare, and there you have some models on the floor, and we do information on infection, how to information about AIDS and how to reanimate somebody. And so this is fundamental. We've been we finance the users ourselves sometimes so that they can be trainers on a peer-to-peer level. And we also have open consumption areas. These have a great visibility with big problems. These are specific neighborhood, and there we have a specific strategy for intervening. And Jean-Pierre knows this very well, but we treat also, and let's not forget this, we're doing it again, we're trying to do it again, we're doing studies with heroin in this case, with oral diacetylmorphine, and it came out, the result was good. It was in a hospital context, so it was controlled, but it gave us a result which at the time, many people said, you're not going to be able to balance the heroin when they take it on the street. You will need such a large quantity of heroin that it's not going to be possible. It's not true. And on the second day, in some cases even the first day, we balanced the dose that the person was normally having on the street. There was a double-blind trial, so neither the professional nor the user knew what they were taking. And it was random, and the decision of who took morphine, heroin, or methadone, and the results were excellent. Now we're trying this out with a new idea also. We'll diacetyl morphine combined with an naloxone, and now I will put myself in the position of prevention of overdose, whose goal needs no explanation. It's a question just of preventing the death with overdose in the largest number of people possible who inject themselves. And this is based on this idea. In Catalonia, mortality because of overdose in the decade of the 2010 was the second cause of death among men between age 15 and 44, and fourth cause of death among women. And in a comparative study in different societies, Rome, Barcelona, Vienna, Lisbon, Hamburg, Dublin, here you can see the Barcelona curve, and that was the city that had the highest mortality rate in 1994 to 1997, the highest mortality rate. So what did we do? We really considered looking at overdose from a clear and profound and explicit approach. Apart from trying to avoid death and overdose, there were other goals to improve epidemiological vigilance, standardize actions in all the centers for drug dependency. As was said before, what are we standardizing with? To train the professionals, Sandra also said that, to train consumers, not only consumers, but also their families, their spouses, the people who live with them, and to combine all of these strategies with the emergency services and police services, because with an emergency like this, we would warn the entire emergency services that there should be a priority, that when there is a warning of overdose should be a priority, and increase the supply of certain services like supervised injection routes and opiate treatment. What are the biggest risks? The loss of tolerance. Imagine somebody who's come out of jail who reduces their consumption or disappears. And there's a period of time which is very important where it is very impossible for an overdose to occur. And when we will see afterwards, quite apart from the program that is being carried, where it is a substitute program or risk reduction, whatever the type is, well, what we do is we do the training and the prevention overdose, because it can crop up any time. Consumption, intravenous consumption, 14 times more possibilities of death than when it is not intravenous. Mix of substances, there's more risk. When heroin or methadone, we mix alcohol, or we mix sedatives, solitary consumptions. We've seen the data. So Sandra presented the data before. In Latin countries, fortunately, it's more habitual to consume in groups or in couples more than in English-speaking countries. So in the southern countries, at least in Spain, we don't do anything alone. We do everything together with someone. And we always go out, and we go out with other people, and always with many people. And so in this specific case, this helps us also. And methadone consumption, of course, without treatment, not prescribed. And I said before, having been in jail for a period of time, here you have the graph to see how the structure is organized. There, the central nucleus, the core of the treatment, are the ambulatory centers for care. But today I'm talking to you about all of these projects and programs which are included within the risk reduction centers, and that is where many of these programs will be piloted that I've been explaining to you. And so the first thing is a center plan. There's a plan for overdose in each center, which is the assignment of somebody who's in charge of the plan and who will also be the clinical head, the design of a protocol, adapted protocol for action, and the training of professionals and the training of users. These protocols will exist. There is a protocol, a framework protocol that we've drawn up for all of Catalonia, but then there's an adaptation to risks reduction, injection centers, therapeutic centers, hospital units, or jails. So therefore, this protocol, general protocol, is adapted in each case to the characteristics of all the different types of centers. A head is appointed for the program. There is training, and we identify the places where the training will take place, and we look for a register to see how many professionals have, how many families being trained, how many professionals have had the training and so forth. And this training for users has some fundamentals. The risk factors for intoxication, we tell them under what conditions and with what characteristics will mean that you will have greater risk. Measures for prevention, how they can identify themselves or their family or people who accompany them, how can they identify an overdose, how to act. And we do this individually and also with groups. And in some places, we work, for example, when in their stay and also when they come out, And this is the algorithm that we use. What do we do in the case of an overdose? The idea is, first of all, assess whether the person is conscious. If that person responds, then we place them in a safe side position. We call the emergency services 112 in Spain, or in Europe, and if they don't respond, or depending on whether they respond or not, then if they breathe, they put them in a lateral position. We call the emergency. We preventively inject one single vial of naloxone, and then we wait for the emergency services. If he doesn't breathe or she doesn't breathe, that's then call the emergency services, inject naloxone, and assisted breathing. And so, therefore, each drug users and their families have this booklet to avoid problems with the police. It says that they're a health agent for overdose, and people who are over age 18 who are able to do this project, who have had contact with a health professional, has this license, which lasts for a year, and that they're given a naloxone kit, and this is recorded every time they go and collect one. This is the naloxone kit. I've got one physically here, and it's on the slide also. And here you have the complete kit. Each user. It's a bit fragile because I've just broken it. Well, it's come a long way from Barcelona, so. Anyway, here's got the mask. If you have to, it's got propylic alcohol. It's got the 2 syringes. It's got some gloves, and obviously there were 2 naloxone blisters, one, and there was a second one because you probably have to inject it 2 times, and so therefore. This is the kit that any user has. But obviously, before they've had a training to use it, of course. And what have we observed with this? First of all, that there are no pharmacological effects without the presence of opiates, so there's not too much risk. And so the average life is much less than heroin. We recommend an initial dose of 0.4 milligrams, followed by another vial, and subcutaneously. Intramuscular, and it can also be intravenous if there's no other alternative, but normally this is used by a health worker. But intramuscular is sufficient, in places where we recommend and we train people to do that are the deltoids and the glutea. And for user, this has got no major difficulties, and everything is accompanied by handbooks in order to prevent. And these handbooks allow you. We publish this. We have videos and capsules also. I don't have time to show you everything, but there's a website also with a platform and an app or application that can help you. In the case of overdose, we have information materials like this, posters, guidebooks, pocket books, simple handbooks to be able to learn. Be careful with overdose, the different places where you can inject yourself, where, how, key places, care with tolerance. There's a calendar with possible uses, how the market, how the methadone, what is the biggest risk, how and consume with somebody, what is the main things to do to prevent it. Is it possible to overcome an addiction? All of these things we try to change behavior, obviously, and these are the results. And I'll finish now. In the data that we have in the Drug Dependency Center of the people who start treatment in the network, there's about 14,000 of them. About 61% of the Spanish and 45% of immigrants declare having had an episode of overdose at some time in their lives. And 19.7 Spanish people and 14.7 immigrants had some overdose incident in the last year, and 83.9% of Spanish people and 64.3% of immigrants received medical care at some stage. And these are the processing data that we have. We've trained 2,109 healthcare professionals or professionals. We have trained 977 to hand out or receive this special educator license. We've trained 9,983 users, not the last year, but over the years. And we have handed out around 11,020 vials of naloxone. That's from 2009 to 2018. So what have we achieved with that? What we've achieved is to reduce the mortality because of overdose, which was in the city of Barcelona in quite a significant way, a very significant way. So the first objective, which was to reduce the mortality. The second one, which was to have greater epidemiological vigilance. The third, which was to increase contact with centers. And the fourth was to reduce mobility. And the fifth objective, which was to improve accessibility. So this is achieved also with an overdose program. And I want to show you this final option. In 2018, of course, we don't know the name of this overdose, but we do know that in 2018 there were 214 episodes of overdose in the room or near the rooms or on the stairs or nearby. The 2018, thanks to the overdose prevention, so there wasn't a single. So the supervised injection rooms are another fundamental element in order to prevent the mortality of these users. So the key of the program are obviously to know that there is a high mortality rate, there's a high probability of overdose, that is the main cause of death among drugs consumers that are avoidable because there's sufficient time to be able to act. And normally death is normally between 1 and 3 hours after consumption, so there's margin for action. It is possible to reverse the situation, as we have shown. We have to use the maximum number of tools that this triad here is fundamental, and we think many people will substitute treatment, supervised consumption rooms, and naloxone kits. And here we have some other items that we would like to have. For example, now we have a prescription that we all do directly from the central services, but we don't have intranasal use, and that would be, and now we give naloxone in this way, but without any prescription. And we're based on the criterion that is given by a professor of an institute when he is allowed to give a diabetic student a dose of insulin. So the value of life is above the value of the professional condition. The same way that a professor who is not a healthcare professional can give insulin when necessary. Why not a drug user? Why cannot a drug user, when needed, supply naloxone? So what is important, therefore, is not the substances, but the people. That is my summarizing sentence.
Merci Joanne pour cette présentation. Thank you, John, for this very comprehensive presentation on risk reduction in Catalonia, which certainly has a number of points in common with the one from Sandra. Now, we have some time for questions from the public in case someone would like to ask a question or make a comment.
Personne ne se lance.
Oh, it seems that nobody has a burning question, or everybody's very shy. We have a show of hand here.
Thank you. I'm Gavin Bart from Minneapolis, United States. I have a question for Sandy. With the training, you had the opioid users and the significant others. Were kits deployed to both or only one? And if deployed to both, did you see a difference, especially in the access to treatment following an overdose, depending on who was the person who actually deployed the naloxone, whether it was the drug user themselves, having maybe witnessed one of their friends overdose and then finally saying, I want to go to treatment, versus the significant other having deployed the naloxone on the drug user and then the drug user saying, now I want to go to treatment. Did who used the naloxone make a difference?
So we really struggled with that when we were designing this study about whether or not to provide the kit to the significant other. We ultimately decided to just give it to the user. I think if we did it over again, we would we would give it to both. So the user was the one who actually had the kit. Not every significant other was living with the user, so we actually only had 28 individual overdose events by the research subject. So there were 170 reported overdose reversals by the subject who reversed someone else. So of the 28 reversals, there were actually a small handful of people who reversed themselves, so they could feel, that they had used too much, and so they kind of, panicked and used it on themselves. The majority of the people of the 28 overdoses among the subjects were reversed by either the significant other that we had identified or, somebody else who was in the household who knew how to use the kit. So, so the number of people who flipped over of those 28 individual or 18 individual patients was pretty low, actually, because those were the ones who actually were not in treatment. And I'd have to go back and look at the data. So we're just now kind of trying to get a handle on everything. Our last data point actually is going to be collected a week from today. So we don't have enough subjects to answer the question about, how many actually went into treatment after they observed an overdose event. Does that answer your question? Yeah. Todd, I think you had a question.
Sí, no, más que nada que complementar.
Well, in addition to what my colleague Sandra said, in our case in Catalonia, we give the complete naloxone kit to users because at some time they have it in. If they don't respond, it has to be somebody else, so we give it to the users, but we also give it to the families who we've trained and the voluntary peers. So the users always have it on them, and if needed, the peer or the family or the significant other can use it and take that kit and use it. But we also give it to family members and colleagues and peers.
USA. A question for Dr. Como and Comer and Dr. Como. I'm curious about the recruitment criteria for accessing the patients in the highest need of overdose. The very impressive work in Catalonia with these harm reduction centers seems like an obvious choice, but it's not one that we can currently scale up in, for example, parts of the rural USA where the need is great. And we're working on projects to do outreach and naloxone distribution in those areas, but it's very challenging in the absence of any infrastructure. And so I'm wondering what your thoughts are of how to actually scale up these naloxone distribution programs in low resource settings.
Yeah, that's a really good question. So in our study, we tried to be as inclusive as possible. So we basically, the inclusion criteria were anybody with an opioid use disorder who, you know, were physically dependent on it. They could be on methadone or buprenorphine. We excluded actually people who were on Vivitrol or extended release naltrexone because we figured that, you know, the likelihood of them overdosing while they're in treatment were lower. You know, I know that the patients who are maintained on buprenorphine and methadone also have a lower incidence of overdose, but they could, you know, stop using their medication and then use heroin on top of that, which we observed actually quite frequently. So, and our exclusion criteria were also pretty minimal. They couldn't have had a psychotic disorder. You know, they needed to be able to understand, you know, read and write English because we were asking questionnaires in English. And so in terms of scaling up, I mean, I think the target population would really be the ones who are ongoing opioid users who are not in treatment. I would target them first. Intravenous users seem to be the ones who, you know, have a greater likelihood of overdosing, so those would be really high priority as well. People who are using fentanyl, I mean, the rate of overdoses were just, you know, skyrocketing, and I mean, when we first started our study, I think we were getting maybe one report of an overdose a month or so, one or maybe two. By the end of the study, it was 1 or 2 a week. Sometimes we got 4 reports a week. It's just phenomenal. So, you know, if you had a patient coming in who is testing positive for fentanyl, who reports injecting, who says that he's using by himself, he has no other kinds of social support, I would very highly prioritize that patient.
Je passe la parole à Joan COLOM.
I'm giving the floor to Joan COLOM. He's going to explain how they decided to disseminate naloxone at a very wide scale.
Yes, if you allow me, I would like to answer the question as well. In our case, perhaps I didn't explain it fully, but the only criterion for exclusion for legal reasons is to be under age 18, and as my colleague Sandra also said, if a person has some serious psychiatric disorder, is not in a condition to be able to act adequately or correctly in case of necessity. But there's no other condition. And secondly, I think that it is a very cost-effective program. It is cost-effective because the cost of the naloxone vial is minimal. The training is probably the most expensive part, and so with few resources, it is perfectly possible to use these kinds of programs, even in more difficult situations. And then with regards to what Véronique was saying to me, what we do in order to disseminate the program, we use the network, the network, the professionals for drugs dependency are the first people who we train in overdose prevention. They, in turn, train the users. And they do that in different places. They do that at the centers and also out on the street, in the vans, in the mobile units, and particularly in the hygienic supervised intravenous injection. There are constantly training classes, and so we use the training and the distribution and the project as a whole anywhere where it can be used. So the only thing we do is to do a program in cascade. We train professionals first. The professionals then form the users, and then the users train other users. Yes, thank you. I will make the most of being on the panel to ask a question. I think the example from our friend Colom is exceptional because it covers all the elements of harm reduction or risk reduction, rather, not only with quality, but also in coverage of the entire region of Catalonia. So does this program, is it comparable with other regions in Spain? And have you noticed in other regions in Spain that there has been such a big reduction in overdose as well? Because if I've understood correctly, 50% less overdose rates in just 15 years. That's the result you've got. Well, it's very difficult to answer that question because I'm a participant, I'm a stakeholder, so I don't have an outside view. But for overdose prevention, this doesn't really exist in other regions of Spain. The national program in Madrid has asked Catalonia to make a project in order to develop it also in other regions, and we're trying to do that. It is also true that the maximum overdose cases are in places where there are the greatest number of intravenous users, and that is usually in the big metropolitan areas like Barcelona, Madrid, Valencia, in the north of Bilbao. But structured in this way, nationally it doesn't exist, but in a meeting, in one of the recent global meetings, we give the presentation of this project for the central authorities, and we encourage them to disseminate the project in other regions in Spain too.
Just wanted to raise one other point that has been a bit controversial in different places that are promoting the use of naloxone for treating overdose, and that has to do with the dose of naloxone that is being used. So I know that Dr. Colom was mentioning that it was a 0.4 milligram dose that's used there. In the US, the intranasal naloxone kit product now contains 4 milligrams of naloxone. So Dr. Strang and I, this is something that's very near and dear to his heart, and I have to say that I'm somewhat in agreement with him. So there's a struggle. You want to give enough of the naloxone that it'll reverse an overdose and save someone's life. On the other hand, the dose of naloxone that is being used now is very large under some circumstances, and it's precipitating very severe withdrawal symptoms. So in terms of the sustainability of the program, the worry is that if the users start to understand that once they give this naloxone dose, it's going to precipitate really severe withdrawal, including increased violence and aggression, which we're capturing actually in our data. I didn't show you the results, but of the rescuers, we asked them what kinds of symptoms that they observed when they rescued someone else and how severe is it. The severity was almost at the end of the extreme for all kinds of symptoms, including vomiting, diarrhea, and we actually had one participant who had an accidental overdose in the lab, so we observed it directly. It was really bad. So, on the other hand, there are lots of reports coming out now about the inability of naloxone to reverse a fentanyl overdose, and reports of, needing to use 4, 8, 12, 16 milligrams of naloxone. So it's a really big struggle. You want to save someone's life, but you also want this program to be sustainable. I don't have a ready answer here. One thing that's really intriguing to me, and I don't know if it'll ever become reality, is that I know in some countries they allow users to titrate the dose of naloxone to effect. So, with the 4 milligram naloxone spray, it just all comes out at once. There's no way to titrate the dose. I mean, I wish there would be a product that would be developed where you can, the user can administer the dose up until the point where they can reverse the overdose, but not beyond that. And actually, in this qualitative study that we ran, Joe Neal in John Strang's group is looking at that very question, and it turns out that the people who were able to titrate the dose up to just the point of reversing withdrawal without precipitating really severe withdrawal were the ones who are more likely to not go out and use immediately afterward. So this is a complicated situation. It's a complicated solution, and but I just wanted to raise that because I think it's really important.
Béatrice.
Pour rebondir sur ce que disait Patrick.
To go back on what Patrick said before, the Catalonian example is excellent. Other people were asking themselves of how you get in contact with the users who are most in danger with overdose. And I think you've answered that. The more you provide risks reduction services that are adapted to this situation, the more you attract people. So you begin with syringes, and progressively you diversify. And in the RdR, this is an evolution with new practices, new difficulties. We adapt, and we congratulate the public authorities when they realize that it's worthwhile putting in a little bit more money into risk reduction, because obviously that would be much less expensive than deaths and disease and illness and repression. So it's better to invest in risk reduction, because that is the way that you can obtain such good figures, such good results. Not perfect, but it's better than the worst scenario. That is risk reduction. Yes, I agree fully with you, Patrice. And I think that one of the things that we've observed is that with this big risk reduction network, which is a physical network apart from a conceptual network, is the place where they distribute the largest number of prevention instruments, kits, and even syringe exchange programs. So although we have 7 points sites, and there we distribute out 1 million odd syringes, where we most distribute is in the supervised injection rooms. And the same with overdose, where we've trained users with the biggest risk, that those are the people who are not in treatment. So the possibility of an overdose is high, and that is where precisely we've had the greatest number of training programs, and where we've been able to recruit the greatest number of users for this program. Any other questions? Miguel, yes. Hello. I just wanted to add, with regards to Joan says one thing, and also to ask a question with regards to about Spain. Yes. It's true, in the rest of Spain, unfortunately, the level of care is much less than compared to Catalonia. apart from the Bilbao injection site, and in Madrid, it was the first one. It opened and then closed in 2012. So, but it's true that consumption the places of consumption has changed, and there was, for political reasons, really in Madrid, the supervised injection room was closed down. I want to add something about Spain. It's true that Catalonia has a special circumstance that there's a lot of people injecting themselves in Catalonia, and other parts they do dragon chasing with aluminium more than injecting. So with the dragon chase, smoking heroin or aluminium, that reduces risks of overdose greatly, even if they still exist, obviously. So it is a characteristic of Catalonia. It also it has to do with the product also, because the heroin that you find in Barcelona, even if sometimes it can be smokable, it isn't so much. It is often a grey type of heroin, which cannot be consumed in that way. So I just wanted to make that little comment. But my question is whether in training in Catalonia or in the United States, do you also teach the users to manage? Because we've been talking here about 4 milligrams of naloxone. The cold turkey that occurs afterwards, the withdrawal symptoms, do you manage the people and the professionals and users? Are they taught to manage that withdrawal situation that often happens? I've heard some comments in emergency services in France of doctors who said, well, that the drug addicts, they're awful. We take them out from a mortal situation. The first thing that they think about is the risk of falling again. We've given them a significant dose, and the person feels bad when they wake up. So in the training, my question is this aspect of management of withdrawal when the person regains awareness and conscience.
So in my study, we did not do that. And in hindsight, I wish we had, because I think it's very important to do that. You know, these are drug users who are rescuing other drug users, and so a lot of times they are reluctant to call emergency services, and they don't go to the hospital, and you know they end up using again. So that obviously increases the risk of an additional overdose. We just submitted the competing continuation of our grant because we really want to drill down to figure out. I mean, you know, obviously when we're talking about feasibility and cost, you know, a 2-hour training is not feasible in most situations. And what we're trying to understand is what components of the training were so important with regard to increasing the probability of people using the kits. And if that gets funded, knock on wood, we'll include a component about that, about training them, you know, how to manage and withdrawal symptoms afterward.
Yes, in our case, indeed, the priority, Miguel, is training in overdose prevention. But since the training is more than just the 2 hours. It's not just one day. There are constant workshops. There are updating workshops. And we also talk about the consequences of use. And our priority is the emergency service. Emergency service is something that we will also make use of. That means that person will go to a medical ambulance. That person will be, or they will have to go into the emergency room in a hospital, and there we make use of those situations. So we are there in the hospitals, in the ambulances to manage the situation. This is an indirect way to try to attract these kinds of users, but we do talk about it. And so, of course, we don't have the fentanyl epidemic, and that is an important difference. We don't have it for the time being, anyway. I don't know whether we will have it. Well, let's hope not. But with these 0.4, frankly speaking, we haven't observed many problems with abstinence or with the immediate use of injecting again. And we make a we do a progression. We say inject one and wait for 5 minutes. If not necessary, with one, it's sufficient. And so the risk of serious withdrawal, abstinence, cold turkey is smaller. So with these figures, with these concentrations, up until now, we haven't detected or feedback hasn't come back to us saying that this happens, really, that it doesn't.
Oui.
Je suis frappé par...
I'm struck by the experience from Barcelona, but I think that there are two dangers to start up these kinds of things when programs work well and where politicians say that there's no problem and then they subsidize it even. And I'm from Belgium, from Brussels, and those who do risk reduction policies, they provide funds. But there are always ambiguities like this, and somewhere the politicians aren't interested in seeing that. So you need a coordinated will with the different levels of power to achieve something, and that is a big difficulty, I think. Thank you for your comment. I think there's another person in the room, but Sandra COMER has to leave it punctually. Well, what you mentioned is very interesting, but I just want to say something from a personal experience. I know this is not scientific evidence, but from my personal experience, I've been working since 1985 in the field of drugs in Catalonia. I've had more than 10 different ministers and councillors. I think it is important that the technical leadership should be able to convey to the politicians the advantage is it cost-benefit terms and for public health. And I say this sincerely. I haven't had too many problems in investing, enacting, and developing programs which were particularly complex and new. So what is very important, therefore, too, is to have leadership, technical leadership, scientific leadership for because otherwise the politician, if the technical head does not give sufficient guarantees or trust, then he begins to be fearful. And you can say that this is the way it works, and that's evident because it improves quality of life and it has a cost benefit that is extraordinary for the health system, apart from the social services. That is my humble experience.
Egunon.
Egunon.
Pregunta era para
My question for Joan COLOM. I'm from the association. I lack it. Perhaps you know us because we do something like energy control with regards to illegal substance analysis in risk reduction projects. And the question, hadn't you thought about including these kinds of analysis system, heroin analysis system in the network? Because one of the risks may be that the real purity is greater than the user is expecting. And these analyses are being done, and there are professionals, but perhaps in the United States also, with fentanyl, it may be interesting to see the real composition of the substance in order to prevent overdose. Yes, indeed. Energy Control is an entity that works shoulder to shoulder with us. We have an agreement with them, and so what we do is the testing of the drugs in the street. But Energy Control doesn't test heroin so much, but mainly synthetic drugs and psychoactive substances in nightlife. So it's more in a leisure context, although have a day collection, but they work more at night with the experimenter of the new drugs experimenter. But what you're saying is very interesting. Why not assess the possibility of measuring the degree of heroin? And there we have a problem of confidentiality and a problem from a police point of view. We, unfortunately, this is why we were talking before about the possibility of using heroin as a treatment, because now we have the entire cycle. Could you switch off your phone, please? Okay. We close the cycle because the person buys the drugs. They go to the supervised injection room, but we do not know what substance is being used, what concentration the substance had. That would be ideal, but that would get us into a complex police control situation. We have tried it, in fact, but what happens with the dose that remains? How do we do the assessment? We're trying to do a prospective survey of that, but what would be ideal would be to have heroin for these people. In this case, it would like it to be oral. Right, instead of this injected heroin that you've bought in the street, we can propose a program, a substitute heroin that is medically prescribed. That would be the ideal situation, but I don't know when we could ever achieve that. Okay, well, we'll now conclude because Sandra COMER has to go. Jean-Pierre, you wanted to talk, so we will give you the floor briefly now.
Bien sûr, remercie.
Thank you. Thank you once more. Thank you, Sandy and Joanne, for these excellent presentations. But I just would like to say that with
longues années,
we have a dream, but we would like to add an extra instrument for risk reduction, and that is to be able to organize an annual ATHS, which would go between Barcelone, chez, and Biarritz. We've been talking about this for 10 years now, and so we call on you all here, and particularly the institutions, those of you who have political experience in Europe, also capacity to be able to mobilize EU aid can help us to have that dream, to make that dream true. So that's what I wanted to say, and all of those of you who want to participate are very welcome. Thank you very much, Jean-Pierre. As you know, and I always say to Jean-Pierre before going, I want to finish this story. Many years ago, more than 20 years ago or 30 years ago, in Sitges, in the town in Catalonia, we had an annual meeting similar to the Biarritz ATH, and there we met. I can't say how many years ago it was, but our commitment was to try to have 1 year in Biarritz, 1 year in Barcelona. So I agree with what Jean-Pierre said. The European organization, the European community, NIDA, if all of these institutions support us, we will be able to achieve that goal of having one conference in Sitges and one in Biarritz.